Okay, picture this. You're facing a topic you absolutely need to nail down. Maybe it's for an exam, maybe a presentation, or you just really want to get your head around something complex. You've got the notes, the source material, but you need to, well, cut through the noise and find the really important bits. That's what we try to do with every deep dive.
Exactly. It's about taking that raw info and turning it into something structured, something memorable, moving beyond just having the facts to actually understanding them.
Precisely. And today, looking at the revision notes you've got, we're diving into a condition you'll definitely come across: benign prostatic hyperplasia, or BPH. We're going to walk through all the key stuff from your notes: definitions, causes, risks, how it works, what else it might be, how common it is, what patients experience, how we investigate, when to refer, management, and the longer-term outlook.
Think of it as us helping you pull out those really crucial nuggets, turning that pile of notes into a clear, focused picture, perfect for revision.
Right, let's jump straight in then. At its very core, what is benign prostatic hyperplasia?
So fundamentally, it's a non-cancerous enlargement of the prostate gland. But the material makes a really important distinction right away.
Which is?
The enlargement isn't because the individual cells get bigger. That's hypertrophy. With BPH, it's actually hyperplasia. That means there's an increase in the number of cells, both glandular and stromal cells, in the prostate. Hyperplasia, that word's key. It's cell proliferation.
Ah, okay. So more cells, not just bigger cells. Got it. And the knock-on effect of having more cells, this growth.
Well, that enlarged prostate gland starts to physically compress the urethra, the tube carrying urine out from the bladder.
Yeah.
And that compression is what directly causes all those urinary symptoms we'll get into.
Okay. Non-cancerous increase in cell number squeezing the urethra. The notes also add some essential context, right, about what drives it and maybe what it isn't.
Yes. It stresses that BPH is hormone dependent. A really interesting point is that it doesn't happen in men who were castrated early on, which, strongly points to hormones being involved in its growth. And critically, the symptoms people get, lower urinary tract symptoms, or LUTS, they're not unique to BPH. Lots of other things can cause LUTS, so you always have to keep those differentials in mind.
That's a vital clinical point right there. LUTS could be BPH, but could be something else entirely. Okay, so if it's hormone-dependent cell growth, what actually sort of kicks this off? What do the notes say about causes and risk factors?
Well, the exact trigger isn't completely understood, but the main drivers seem to be hormonal, specifically an imbalance with increased levels of dihydrotestosterone, DHT, relative to testosterone. That seems pretty significant.
DHT, that's the more potent form of testosterone, right? And I assume age factors in here, too.
Oh, absolutely. Age-related changes in sex hormone levels, shifts in growth factors.
Yeah.
They're definitely part of the story, creating an environment where this cell growth is more likely.
Right, so hormones and aging are the big drivers. Who's most likely to end up with BPH then? What are the main risk factors you should have on your radar?
The material lists several pretty clear ones. The biggest, unsurprisingly, is advancing age, especially hitting men over 50. It's pretty uncommon before 45.
Age over 50 is number one. What else?
A family history definitely bumps up the risk. Obesity is mentioned, which often links into wider metabolic health issues. Hormonal imbalances are listed, naturally connecting back to the cause. And interestingly, diabetes and heart disease also make the list of risk factors.
That's quite a collection: age, family history, and then this sort of cluster. Obesity, diabetes, heart disease, hormones. You could almost bundle those up as like the aging man's metabolic and familial risks. Might make it easier to remember for revision.
That's actually a pretty good way to frame it. Age and family history, you can't change those. But that metabolic connection with obesity, diabetes, heart disease is really noticeable and might suggest some, shared underlying processes.
Okay, so we know what it is and broadly who gets it. Let's go a bit deeper now into how it actually happens inside the prostate, the pathophysiology bit.
Right. It comes back to that key point, the proliferation, the increase in number of glandular and stromal cells. This just makes the prostate tissue bulkier overall.
And that extra bulk.
Specifically where it's growing, in what's called the transition zone around the urethra, physically pushes in on and squeezes the urethral passage.
Like stepping on a garden hose.
Pretty much, yeah. That squeeze increases the resistance the urine faces trying to get out, causing bladder outflow obstruction. The material does say the whole process is complex, influenced by those hormonal factors. Genetic predisposition, even inflammatory factors might play a role, all feeding into this uncontrolled but still non-cancerous cell growth.
Okay. And given that LUTS symptoms are so common, and like we said, could be caused by lots of things, Thinking about the differential diagnosis is absolutely crucial. If someone comes in with these urinary symptoms, what else needs to be on the list?
Yeah, this list is non-negotiable for practice and revision. Top of the list, the absolute must not miss, is prostate cancer. You simply cannot afford to confuse BPH with a malignancy.
Agreed. That's priority number one.
Hmm.
What other conditions often present like BPH?
Well, urinary tract infections, UTIs, are super common and can give you very similar irritative symptoms. Then there's bladder dysfunction, things like neurogenic bladder, where nerve issues affect how the bladder works. That can look similar too. And you've got to think about actual physical blockages in the bladder or urethra, like bladder stones, maybe even bladder tumors or past trauma.
Any other structural or inflammation issues?
Definitely. Urethral strictures, basically narrowings in the urethra pipe itself, they can cause flow problems. And conditions like chronic pelvic pain syndrome, chronic prostatitis, which is inflammation of the prostate gland, and interstitial cystitis, they can all show up with overlapping urinary symptoms. The notes really emphasize casting a wide net initially when someone presents with LUTS.
Wow, that list really drives home how important a proper workup is. Getting that differential diagnosis right changes everything in terms of treatment.
Exactly. Treating a simple UTI is worlds away from managing BPH, let alone in investigating potential cancer.
So how common is BPH? How often are clinicians actually seeing this? Let's look at the epidemiology, the UK numbers the material mentions.
It is incredibly common, especially as men get older. The notes say about 50%, half, of UK men aged 50 plus have histological evidence of BPH. That means the cellular changes are there if you actually look at the tissue under a microscope.
Half of men over 50 just have the signs of it. What about symptoms? How many are actually bothered by it?
The impact on quality of life is huge. Around 40% of men in their 50s say they have bothersome symptoms, and that figure just skyrockets with age up to 90% for men in their 90s. It's clearly a massive issue for aging men.
And it really is tied to age, being rare before 45. The material also pointed out a difference in certain groups.
Yes, it specifically mentions that Afro-American men tend to be more affected. The reasons suggested include things like potentially higher testosterone, maybe more activity of that 5-alpha reductase enzyme, converting testosterone to DHT, greater expression of androgen receptors, and differences in growth factor activity. It implies a sort of complex biological predisposition.
Interesting detail. And does the actual size of the prostate track well with symptoms?
The notes say there's a correlation between how bad the LUTS are and how big the prostate volume is, but it's not, a perfect one-to-one relationship for everyone. Prostate size generally increases over the years, often doubling quite fast between 31 and 50, then maybe slowing down a bit, though the length seems to increase faster, especially after 60.
Okay, so it's common, gets much more common with age, and can really affect quality of life. What does it actually feel like for the patient? What are the typical clinical features?
The classic picture is those lower urinary tract symptoms, LUTS, which you can kind of group together. The notes list them out pretty clearly.
Let's break those down.
Okay, so you've got the storage symptoms. These are more about the bladder feeling irritated or not holding urine well. Things like urinary frequency, needing to pee often, urgency, that sudden gotta go now feeling, and nocturia, specifically waking up at night because you need to urinate.
And then the voiding symptoms, the ones related to the blockage itself.
Exactly. These are about the difficulty getting the urine out past that squeeze.
Yeah.
So a weak urine flow or stream. Difficulty getting started, that's hesitancy. Trouble keeping the flow going, maybe straining, the stream stopping and starting, and that annoying terminal dribbling at the very end. And often a feeling that the bladder isn't completely empty afterwards.
And if it gets more severe?
Well, the blockage can lead to urinary retention being unable to pass urine at all. That can be acute, meaning sudden and painful, or chronic, developing over time. Chronic retention can sometimes cause overflow incontinence, where the bladder is so full it just leaks. And the blockage is really bad for a long time. The back pressure can eventually damage the kidneys, leading to what's called obstructive nephropathy.
Right, so a whole spectrum of symptoms, but they all kind of logically flow from that physical squeeze, making it hard to store urine comfortably and empty the bladder properly.
Precisely. And the material mentions severity is often graded mild, moderate, severe, which helps decide on management, often using tools like the IPSS symptom score questionnaire.
Right. Speaking of figuring things out, how do you actually diagnose BPH and rule out all those other potential causes? What are the key investigations?
It really starts with taking a good history, drilling down into the specifics of the LUTS symptoms and how much they're bothering the person.
And then the physical exam.
Absolutely crucial. An abdominal exam might pick up a palpable bladder if there's a lot of chronic retention. And then the digital rectal examination, the DRE. This lets you feel the prostate size, its texture, its shape or contour.
What are you feeling for in the DRE that points towards BPH specifically?
The notes highlight this well. Typically in BPH, the prostate feels enlarged. It's firm, but not rock hard, and it feels smooth, without any distinct lumps or nodules. This is a really high-yield point. If you feel a prostate that's hard or has nodules, that's a big red flag for prostate cancer and needs urgent further investigation.
Okay, so smooth and firm suggests BPH, hard or lumpy is worrying. Any other parts of the physical exam mentioned?
Yeah, the material mentions assessing general health, especially cardiovascular and respiratory fitness, which is important if you're considering surgery, particularly in older guys, and maybe a neurological exam if you suspect something like a neurogenic bladder might be contributing.
Beyond the hands-on exam, what tests are essential?
A urine analysis, or UA, is pretty standard looking for infection, blood, hematuria, and a PSA blood test, prostate-specific antigen. That's vital, mainly to help rule out prostate cancer, as we said.
A significantly raised PSA needs following up.
PSA for the cancer check. What about imaging or functional tests? An abdominal ultrasound is really useful. It can give an estimate of the prostate volume, which can be helpful. It's also key for measuring the post-void residual volume, the PVR. That's how much urine is left in the bladder right after someone tries to empty it. A high PVR is a strong sign of obstruction. Ultrasound can also spot complications like kidney swelling, hydronephrosis, or changes to the bladder wall. Prostate ultrasound can also help guide treatment choices.
And that uroflowmetry test.
Ah, yes. That measures how fast the urine flows out. The notes mention that a peak flow rate under about 10 milliliters per second, if it's thought to be due to BPH obstruction, might suggest surgery could be a good option.
Are there other, maybe more specialized tests sometimes needed?
Yes, definitely. PVR can be measured more formally with ultrasound, as mentioned. Pressure flow studies are more involved, urodynamic tests that can really nail down if the problem is true blockage versus just a weak bladder muscle. And endoscopy, usually with a flexible cystoscope, might be done if you suspect something specific, like a urethral stricture or perhaps a lesion inside the bladder.
That lays out the investigation pathway nicely. Now, something that's always super important for revision, when do you have to refer someone onwards? The material gives specific criteria, often based on inside guidelines here in the UK.
Yes, this is absolutely key. There are situations needing immediate hospital admission.
Immediate admission sounds like emergencies.
They really are. Acute urinary retention, suddenly being completely unable to pass urine. And acute kidney injury, if the obstruction has caused sudden kidney damage. Both need sorting out in hospital right away.
Okay, immediate for acute retention or kidney injury. What about things needing Regent referral, say within 2 weeks?
The notes list a few for that 2-week pathway. Visible hematuria, seeing blood in the urine, any suspicion of prostate cancer from the DRE, that hard or nodular feel, or a raised PSA. Also something called culture-negative dysuria, that's painful urination where the urine tests don't find bacteria. It suggests something else is going on. And chronic urinary retention that's causing overflow leakage or significant wetting the bed at night.
Right. 2 weeks for visible blood, suspected cancer, painful wee without infection, or chronic retention with overflow. Are there other reasons to refer that maybe aren't quite as immediate?
Yes. Things like recurrent UTIs that keep happening despite treatment in primary care. Microscopic hematuria blood only seen on the urine test strip or under the microscope, or simply that someone's symptoms are still really bothersome and affecting their quality of life, say measured by that IPSS score, even after trying initial treatments.
That breakdown is really practical. You can almost group them, get them to hospital now, emergencies, the rule out serious stuff quickly, 2-weekers, and the need specialist input for ongoing problems.
Yeah, thinking about it in those categories definitely helps cement it for exams or, actual clinical decisions.
Right, so you've done the assessment, the investigations, and you've concluded BPH is the main issue. How do you actually manage it? What are the options?
Well, management really depends on the individual, how bad their symptoms are, and how much it's impacting their day-to-day life. It's a spectrum, really, from just keeping an eye on things right through to surgery.
What's the first step if symptoms are pretty mild?
Often, watchful waiting is perfectly reasonable if the symptoms aren't causing much trouble. And alongside that, or even before medication, lifestyle changes are recommended for pretty much everyone.
What sort of lifestyle things are we talking about?
Simple stuff, often, like managing fluid intake, especially cutting back fluids in the evening to help with getting up at night. Maybe avoiding things that can irritate the bladder, like alcohol and caffeine. trying techniques like double voiding to make sure the bladder is as empty as possible. The notes also hint that general diet and exercise might have a role too.
Okay, simple measures first. What about when medication is needed? That seems like the next logical step.
Yes, medication is very common. The material talks about two main classes. First up are the alpha blockers. Examples you'll see are things like tamsulosin, alfuzosin, doxazosin.
And how do they work?
They basically work by relaxing the smooth muscle cells in the bladder neck, where the bladder meets the urethra, and within the prostate itself. This relaxation opens up the channel a bit, reducing the resistance to urine flow. It helps ease symptoms, even if the prostate doesn't actually shrink. The notes say they tend to work pretty well long-term.
So alpha blockers enclose relaxation for better flow. What's the other main group?
That would be the 5-alpha reductase inhibitors, or 5-ARIs. Examples are finasteride and dutasteride. These work quite differently. Remember that enzyme, 5-alpha reductase? It converts testosterone to the more potent DHT.
Ah, yes, the hormone we talked about right back at the causes section.
Exactly. So these drugs block that enzyme. By reducing DHT levels, they can actually cause the prostate gland to shrink over time. It usually takes a few months to see the effect. The material does flag potential side effects, though, particularly things related to sexual function, like erectile dysfunction or reduced libido.
Right, so alpha blockers relax, 5-ARIs shrink. Any other drug types mentioned?
Yes, parasympatholytics, like oxybutynin. These are sometimes used for those bothersome, irritative, or storage symptoms, like urgency and frequency. But, and this is a big C, but the material emphasizes they should generally only be used if there isn't a high post-void residual volume. Because they relax the bladder muscle, they could actually make retention worse if there's already significant blockage.
That makes total sense. Like, you don't want to weaken a bladder that's already struggling to push against resistance. And any general side effects across these meds to keep in mind?
Yeah, the notes mention things like potential dizziness or low blood pressure, hypotension, especially with alpha blockers, erectile dysfunction, as we mentioned, with 5-ARIs, and sometimes headaches.
Okay, so if lifestyle and medication aren't cutting it, or if complications develop, that's when surgery comes into play.
Pretty much. Surgery is usually reserved for when medical therapy hasn't worked well enough, if the prostate is particularly large, or as specific complications arise. The notes list clear indications. Things like acute urinary retention, especially if someone fails a trial without a catheter afterwards, recurrent episodes of visible blood in the urine, recurrent UTIs linked to the BPH, any sign of kidney damage due to the obstruction, or just persistent severe symptoms that medication hasn't fixed.
And the material listed quite a range of surgical options.
You really did. TURP transurethral resection of the prostate is often seen as the kind of traditional gold standard. That involves using a scope passed up the urethra to basically shave away excess prostate tissue from the inside using heat. For really massive prostates, sometimes an open prostatectomy is needed, where the enlarged core is removed via an incision in the lower abdomen.
What about less invasive techniques LUTS mentioned there?
Yes, several. There's TUVP transurethral vaporization, which uses high heat to vaporize tissue instead of cutting it. The Urolift system is interesting. It uses tiny implants, a bit like treasury tags, to physically pull the obstructing prostate lobes apart, opening the channel. It's often highlighted for preserving sexual function better than some other methods. Then there's HOLEP, holmium laser enucleation, which uses a laser to core out the enlarged tissue, often allowing for quicker recovery, sometimes even as a day case.
And some even newer approaches.
Right? Resumu was mentioned, proved by NICE. It uses steam energy, water vapor, to treat the tissue, and is also noted for having a low rate of sexual side effects. Things like 2IP just making incisions in the prostate neck for smaller glands, or TUNA using needle ablation are alternatives. And prostate artery embolization, or PAE, which involves blocking the blood supply to the prostate to make it shrink, is mentioned as a newer technique still being evaluated.
Wow, quite the toolkit. So lots of options depending on the patient, prostate size, symptom goals, potential side effects. But the notes did add a little warning about surgery.
Yeah, just a reminder that even surgery might not be a permanent fix for everyone. Symptoms can sometimes return later. And, like any operation, all these techniques carry potential risks and complications that need to be discussed. Regular follow-up after any treatment pathway is important.
Okay. We've covered diagnosis, the wide range of management. What's the general outlook for someone with BPH, and what are the main complications we need to watch out for? Prognosis and complications.
Generally speaking, the prognosis with BPH is pretty favorable if it's managed appropriately. The treatments we've talked about can really provide significant symptom relief, and improve urinary function, which obviously boosts quality of life.
But it's not always a complete cure. Symptoms can linger or come back.
They can, yes. For some men, symptoms might be chronic, maybe slowly progressive, and continue to impact quality of life even with treatment. That's why that ongoing monitoring is key to catch any worsening or to spot if complications are developing.
And what are those main potential complications that can arise from BPH, especially if it's not well managed?
The notes list the common ones. Recurrent urinary tract infections are definitely up there. Bladder stones can form, partly because urine might not empty completely and sit stagnant. Acute urinary retention, that sudden inability to pee, is a major potential issue. And chronic kidney disease is also listed as a possible long-term consequence of back pressure, although the material suggests this is perhaps less common now than it used to be, likely because we diagnose and treat BPH earlier.
So the complications really stem directly from that bladder outflow obstruction, the urine stasis, the back pressure.
Exactly. The blockage makes UTIs more likely, can lead to stone formation, and over time can strain the kidneys. It can also be a cause of blood in the urine, the hematuria.
Now, a really, really crucial point, the material makes sure to hammer home, something that's often misunderstood.
Yes, absolutely vital for revision and understanding. BPH is not a premalignant condition. It does not turn into prostate cancer. Having BPH doesn't increase your risk of developing prostate cancer. They're two entirely separate disease processes that just happen to affect the same gland.
That is such a fundamental distinction, worth repeating. And speaking of cancer, the notes did briefly mention screening.
Just touched on it, yeah. Mentioned that while some guidelines or doctors might recommend annual screening for prostate cancer with DRE and PSA, it's not something that's universally agreed upon by all medical bodies. There's still ongoing debate about the overall balance of benefits versus harms of population-wide screening.
Okay, wow. We have really covered the landscape of BPH based on that material. We went from the basic definition, remembering it's hyperplasia, not hypertrophy, through the hormonal links, the age and metabolic risk factors, the mechanics of urethral compression, that crucial list of differentials, the sheer prevalence, the whole spectrum of LUTS symptoms, the key investigation steps like DRE, PSA, ultrasound, those critical referral triggers, the huge range of management from lifestyle tweaks to meds like alpha blockers and 5-ARIs, through to all those surgical options like TURPE, HOLIP, URLEAF, RESUM, and finally the prognosis, potential complications, and hitting home that absolutely vital point that BPH is not cancer.
Yeah, hopefully breaking it down like that, pulling out those core concepts and seeing how they all connect really helps solidify things and makes it much more, high yield for revision or just getting a handle on it.
Absolutely. And as our population continues to age, conditions like BPH are only going to become more common in practice. Understanding that balance managing symptoms effectively to improve someone's life while staying vigilant for potential complications or other serious diagnoses like prostate cancer, that's just fundamental.
Definitely. Keep digging into the material. Keep asking those questions.
And for more resources that might help with your revision, don't forget to check out PassThemSRA.com and FreemSRA.com.